Our next series is a series on methadone deaths by the Seattle Times. Some time ago, some doctors approached reporters at the Seattle Times and told them there were too many people dying of methadone overdose. The result of that conversation was a three-part series that exposed how more than 2,000 people in Washington state fatally overdosed on the painkiller methadone. Accidental deaths resulting from overdosing on prescription painkillers is not a new issue. Last year, the Center for Disease Control labeled these deaths an epidemic, with the death toll more than tripling in the past 20 years. But Michael Berens and Ken Armstrong found something new and unique about the deaths in their state. Most of the methadone deaths they found were of poor people. In the past 8 years, Washington had steered to methadone those with state-subsidized health care, such as Medicaid patients, injured workers, and state employees. This was because methadone is cheap. Low-income patients were often given no other choice. Many of them were not told that the drug lingers in the bloodstream for days, potentially building to toxic levels. It can also paralyze the respiratory muscles, so patients could just stop breathing and die. For sure, the drug saved the state money, but poor patients paid for those savings with their lives. The Seattle Times team got the data on more than 2,000 people who had died of methadone overdose. Then they located the fatalities addresses on a map. Each red dot on that map represents a methadone death. The team found that in the lowest income neighborhoods, the death rate was 3 times higher than in affluent areas. The richer parts, like Mercer Island, where folks like Bill Gates live, have no methadone deaths at all. Washington's death rate from methadone ranks among the country's highest, yet state officials had done little to address the issue. Instead, they passed a law that imposed restrictions on doctors, who can only prescribe painkillers up to certain dosage levels. As a result, hundreds, maybe thousands of patients were turned away by doctors and denied pain medicine. Meanwhile, methadone prescriptions were on the rise, given by clinics like the one featured in this report, where 6 patients had fatally overdosed. Pharmacies, medical providers, patients, the county sheriff, even the Drug Enforcement Authority had filed more than 100 complaints about this clinic, yet state regulators didn't take any action. The impact of the series was immediate and dramatic. Within days, the state issued an emergency public health advisory warning of the unique risk of methadone as a pain drug. Within weeks, the state also declared methadone no longer the preferred drug for chronic pain management. And for the first time, the state warned patients that methadone should only be used as a last resort. Michael Berens, I'm a big fan of this series, which I first read last year. This issue was brought to your attention by medical professionals concerned about the accidental deaths from methadone overdose. How did you go about reporting it? Did you have some idea in the beginning what the story would ultimately be focusing on?
Well, let me go off the reservations for a second and just say to the crowd, thanks for showing up tonight. When I was at Ohio State back in 1979, there was this guy named Frank Reynolds, I believe, a dignitary from the networks, and he was giving a speech, and I happened to wander into a hall like this one, and I was sitting in the back of the room, and I was in a pre-law kind of major, and I listened to this guy, and he was broadcast, but he's talking about journalism, and it so inspired me that I switched my major the next day and went into journalism, and you know, it was just sitting in a crowd like this saying, you know, there's something electrifying about this, and so what I wanted to say very quickly before I get to the question is thanks, you know, for being here too. Journalism is great. Don't let anyone tell you it isn't. And investigative reporting is alive, and you can make money at it, believe it or not. I think we all, you know, make a little bit of money here, and so there, you know, I just want to say, you know, there is nothing like this profession, and I'm here because, you know, I love what I do. So let me get to the question. Yes. How do I know, and how did the story come to me? And I brought a copy of the original email with me. I'll just read you the first paragraph. And I'll tell you, this is the challenge with investigative reporting. But here's the story tip. It came as an email from a doctor in Washington. The core story is that state agencies are allowed to perform therapeutic substitutions within any drug class, such as long-acting opioids, and generate preferred drug lists, i.e. pick a cheap drug based on non-transparent rebates with pharma, as long as the State Pharmacy and Therapeutics Committee, under Healthcare Authority, determines there is no evidence that any drug within that class is any riskier. I don't know about you, but that screams Pulitzer, doesn't it? I mean, you know, you read that and it's like, wow, this is it. This is my career. No, you know, it was the most incomprehensible, unbelievably dense email, and it was really tough to get through. And it went for about 3 pages, you know. And you get these kind of emails all the time, and I'm sure, you know, you look at, oh, here's another guy ranting about the government or whatever. But you know, you read it, and so the secret to my approach is I have a checklist that I use for determining what makes a story. I put my web page up there on the board. Watchdogreporter.com. My handouts are on there. So there's a handout with this checklist. It's a 10-point checklist. It's nothing magical. It's just common sense information. But what I look for most of all, and what I looked for when I read this email, is this something new? Is there something, a twist that I can report on here? Most importantly, is this something that I can quantify? And what this doctor said is that there are deaths linked to methadone that no one wants to acknowledge. And the real core simple issue, you know, what is the reform? You know, why am I doing this story? Is there potential reform? And what I saw in this email is the state is giving out a drug and they're not warning people about how risky it is, and people are unnecessarily dying because they're unaware of the risk. You know, very simple concept at its core. Complex story, kind of a niche in the healthcare system, but very simple, and here's what my mission is. My mission is to inform the public about the risks of this drug when I've got the state of Washington say it's not risky, it's just as safe as any other drug.
Great. So how did you get the evidence to bolster that story, to prove that story? What did you do next?
My first step in these projects, as I said on this checklist, the most important criteria for me is quantification. Right. So when I read a story, the thing that drives me crazy when I read investigative stories, there are about 100 deaths linked to this, or there are estimated to be 100 deaths linked to this. What I like to do is come in and say there were 97 deaths linked to this. I like the precision, you know, the precision journalism. So what I look for is a way to quantify. So in the state of Washington, we're fortunate because death certificates are public records. And so we obtain the database of every death for 10 years in the state of Washington. There's approximately 40,000 plus deaths a year. And with each computer entry, I got probably 30, 40 pieces of information about every death. What was the primary cause of death? Was it accidental or intentional? Was there a crime involved? What were if there was drugs, if it was an overdose death, it would tell me what the primary drug was in the body and show me any secondary or third drugs. So by putting them into a database, I was able to look at every person who had methadone in their body at the time of death, and whether methadone was the sole drug in their body or whether there were other drugs such as benzodiazepines, which are often common for depression or those kinds of other issues. And so we were able to very quickly categorize the population of deaths.
Then when did you have the idea to map those deaths, to put those that, to map the addresses of those who had died, which was, the
mapping
core
came,
of your story?
When did we have the idea for mapping? It was right away, very from the beginning. Let's show people where the deaths are. And part of the reasoning for us, and it started off as just a simple dot map with not the layer of income, which came later as we started learning more about this. But visually, I just like to, every project I do, I just like to show people where's it at. And what I like to do for the reader is this isn't some esoteric topic that affects, other people. Here's someone probably in your neighborhood. Here's someone in your zip code. And that was the first purpose of the dot map, was to say, here's where the people are. This is real. These are our neighbors, and these are people you should care about.
Michael, why don't you come and show us?
Okay. So this is the dot map, and what we did is made it interactive so that you got beyond just the one surface level of here's where they're at, and we tried to show here's the differentiation in income. And this came towards the end of the project as we realized the state program that picks which drugs people have to take is a state program that primarily caters to Medicaid recipients. And so we started wondering, well, I wonder if most of the deaths then are Medicaid deaths. Even though any doctor can prescribe methadone, if they have a choice, is methadone the first choice or not? And so when we started mapping this, we started color coding the areas. And basically, the darker areas are the wealthy areas in the state of Washington, and the lighter areas are the low income. And so let's take a look here. Here's Mercer Island. And so if you click on the island, you can see here, we have a pop-up that shows that this is a $1,000 to $185,000 median income based on census data, and as you can see, there's not a single dot in Mercer Island. But you go over here where there's a lot of dots, and you'll see that this is a $0 to $45,000 census tract. And then when you click on the individual dots, you were able to see what year this person died, and we gave just some general information. And I can explain that later if you want, but the reason why we didn't give more is because we didn't want to unnecessarily embarrass specific families. We're even worried about how far we allow people to drill down on the map, because with today's mapping, you can actually drill down to the house, particularly with satellite imaging, and we were scared that this would cause harm and unnecessary hurt to families, so we only allow people to drill so far down. But with the slider here, you could go really minute if you wanted to, or you could pull back far away and see the mass of dots. And our purpose was to show people, we're not making this up. This isn't some manufactured media issue, that we're trying to make. This is very real. And when you have 2,700 deaths in the state of Washington linked to this drug, and so we allowed people and gave them the power, to go into their specific neighborhoods. And boy, it's hard to find, as you drill down into the specific neighborhood, and you start seeing the differential where there are, obviously people died in the wealthier areas as well, but the majority of those deaths were in the low-income areas. And it becomes very stark as you know the area and you start looking.
Michael, did you find that with this database, people engage with the story in a different way, in a way they would not have done if it was purely a text story?
I think the power of the data and why we invest so much in it is that it allows people to look for themselves and see the proof for themselves. In other words, don't just look at the story, but look at the data. It also plays a dual role with telling the state, we know what we're doing here. And it helps when you're doing your final interviews, instead of saying, we have people tell us there's methadone deaths and that there's a bunch of unnecessary deaths out there. And the state of Washington maintained all along, there's not that many deaths, you don't know what you're talking about. So we can hand them those databases, as Philadelphia did with the schools database. We handed all of our data to the state of Washington prior to publication, said here's all 2,700 of them. Here's the circumstances. We know everything we can possibly know. Tell us where we're wrong. And they couldn't. And that's, again, the power of this.
You chose to tell this story by telling readers about one of your main characters here is Angeline. There were 2,000 deaths from methadone. How did you pick Angeline to represent those 2,000?
Why do we choose Angeline Burrell, as our signature patient? In every project, we call that sort of in the project the signature victim. And you're looking for someone that embodies all the characteristics of your readers, if possible, because that's who we're writing for and that's who we want to identify with. The problem with pain patients, if anyone has encountered this in their own families, it's often a tragic, prolonged kind of storyline. And people often blame pain patients for their own problem because pain can't be measured. You can't see it in an x-ray. So someone sees, a family member who says that they're suffering from pain, they start taking drugs for it, and then they start into a cycle of depression and maybe overeating and all kinds of things, and it goes on for years, and people start to blame the patient after a while. And this is what happened to Angeline Burrell. But why we picked her is because she could be you. And that's really the power of Angeline Burrell. Here's a woman who has a committed relationship. She has a child. She owns a home with her companion. She works as a 911 dispatcher for the King County Sheriff's Department. So she's employed, everything. She's living the perfect, middle income lifestyle. And then she has an operation for a gallbladder. There's a surgical complication, and something gets nicked in her stomach that was not accounted for, and she's left with this unbearable, unaccountable pain. The doctors can't figure it out for 2 years. Meanwhile, the pain is just chewing away her life. She can't function on her job. Her employees, her fellow deputies, and everyone were giving her their sick days to use. This is how beloved she was and how respected. And as the pain ate away her life, she ended up losing her home. She was trying to find medical treatment. It took 2 years to actually get diagnosed with someone saying, yeah, there's a legitimate reason for your pain. But by then, she had lost her home. She's on Medicaid. She'd lost her insurance. And after she lost her private insurance, she was put on Medicaid. And when she was put on Medicaid, she went to a clinic that said, you should go on methadone now because that's the preferred drug. 2 days after she was upped when her medication was upped on methadone, 2 days after she was given her methadone dosage, she died. And the reason is because methadone will kill you in the first few days of use. That's why they call it the silent death. Some people react to it worse than others. Some people are less tolerant, and it stops you from breathing. Angeline Burrell was found sitting up in her bed, palms open. She had just stopped breathing as she was trying to get up out of bed. That's why we picked her. That's why her family was incredibly brave for coming forward and telling, what is a very painful story.
I'll ask our audience now to ask their questions of Michael. Yes.
Hi, my name's Annie Zach. I kind of have two questions. The first is, for someone that might be embarking on a health-related or medical-related story, what resources or lessons have you learned from covering that beat that you find kind of most helpful? And also, specific to this story, what do you do after you publish something of this magnitude investigative work? Going forward from a watchdog angle, how do you plan to pursue it, or how are you pursuing to sort of check in and see how regulations change in the future?
So the first part of the question again was
the resources.
Resources. How, what I'd recommend quickly. There is no topic that you can pick in America where there isn't someone in their basement who's devoted their entire life to tracking it. And I try to find that person in the basement, who's got the moldy file cabinets and all the paper. But literally in healthcare, there are so many advocacy groups out there. So when I was doing a story about the exploitation of the elderly, for instance, I got together with the Ombudsman's office in the state of Washington, and here's my technique for finding victims, is find an advocacy group that deals with the subject, ask them to go through all their email that they've received for the last couple of years and find everyone on point to your story, have them email those people on your behalf and tell them, would you like to talk to the Seattle Times? And a certain percentage of those people are going to email back to the organizations. I'd love to talk to them. And now I've got a list of 20 people who want to talk to me about my core topic in the area and the specific geographic location that I'm looking for. So it's a technique I've used in healthcare a lot. As far as, again, the second part, I'm trying to think.
What do you do after?
How do you follow up with this? I'm sorry. It's hard when you're a project reporter. I don't know how. I'd be interested in the other answers to this because you have to move on. We are planning follow-ups on methadone. You will check in a year later, maybe 2 years later, to see whether deaths have gone down, and we'll try to do some annual story. And we've done that with some of the other big projects that we've done too.
Maybe we'll go to this side of the room. Yes.
Hi, Jenny Zhao. I was wondering, in some of the stories in the series, you had, current patients who were sort of, discussing whether to use, the OxyContin or go with methadone, a cheaper drug. How did you get access to, current patients? Did you have any pushback from health privacy laws or issues like that?
Again, we went through organizations, that dealt with pain, and we asked them to help us find patients who would talk to us. In some cases, we went to our beat reporters at the paper and asked them to look at their contacts, people who had messaged them over the years. So one of the families we used in the series had actually contacted our healthcare reporter, our beat reporter, Carol Ostrom, and asked them, asked Carol to do a story like a year earlier, and it wasn't something Carol was interested in or able to do at the time, but she had saved the email, she passed it on to me, and I contacted the family. It became an on-point family for us.
This side? Yes.
Hi, Hendrik Hinzel. I was wondering when and why you decided to publish your research in a series and not just one single article, especially if you had one really strong character. Was it from the beginning, or was it later on when you found this actually affects a lot of people?
When we start a project, like I said, we kind of have this criteria, what makes a project, and we very quickly realized once we saw how many methadone deaths were in the state of Washington that we had an issue that affected a lot of people. The reason why we chose to write it as a series is we tried to cover the spectrum of issues that go with the topic. Sometimes doing just one story, if you try to pack it all into one story, it becomes too confusing and too many different diverse issues. So the first story was really convincing people that there's this problem with methadone, and it's complex because there's this obscure state committee that's involved. The second story was about what about legitimate pain patients who are losing access to their drugs. And the third story, part of the series, was let's admit it, there are some bad doctors out there, bad practitioners, and they're part of the problem as well.
Yes.
Hi, my name is Stuart Sia. My background's in public health, and I was very impressed to see your use of mapping software to look at this issue. It's actually a relatively new trend in epidemiology to use GIS to try to understand non-infectious diseases like obesity, for example. So I'm wondering, like I said, it's a relatively new thing in public health. What sort of drew you in that direction to think, maybe we should start looking at this geographically? Was there something that drew you in that direction?
We've been using, the ArcGIS software for years, with our stories. And I think, again, it was about 3/4 into this project when we realized what the role of income played to the nature of our victims. And that came from looking at the death certificates. We kept seeing a number of deaths on the south side of King County, which tends to be the lower income. And I started thinking, wow, I wonder, what role income does play, whether there is some type of relationship. And so we started looking, and when we saw it, as you said, it's too stark to ignore.
Next question, please.
I remember back in the 60s or 70s, there were such places as methadone clinics where heroin addicts would show up for a dose of methadone, which was supposed to wean them away from their addiction. How did methadone metamorphosize into this universal painkiller?
Maybe before you answer, we'll ask the last person in the queue to also ask a question, and then we'll answer both your questions in one go. Just to save time, I'm sorry. Yeah.
Hi, my name is Maria. I just wanted to ask a general question. You said that your newspaper makes money off investigative journalism. How do you do that? How do you persuade your chief editors that it is worthy, that not worthy because it's worthy, but it is economically sustainable?
Okay.
What's your business model?
Let me answer the methadone clinic first. This was a hurdle with the story. Most people know methadone as a drug used to wean heroin addicts. And so there was a shift about 15 years ago where, because states were looking for the cheapest drugs that they could, they realized that methadone's indications also for use as pain. It's always been a pain drug, but it wasn't embraced until states started adopting these kind of prescription drug programs. And so if you look at the DEA charting, methadone usage, not only in Washington, but in every state in the country, has just skyrocketed because it's become a mainstream pain pill. Where OxyContin costs, say $12 a dose, methadone costs a few pennies. And that's why it's become such a popular pain drug. As far as finances, investigative journalism, trust me, the paper doesn't sell a single ad from a story that I do. They make no money from investigative reporting. Excuse me?
They win Pulitzers.
They win Pulitzers, but Pulitzers don't keep papers afloat, and there's a lot of testimony to that, I think. I think what it does do, though, is it brands us with our readers, and our readers come to expect this level of journalism in the Seattle Times, and it does, I think, reflect in subscriptions. I think it does reflect in reader loyalty, and fortunately I work for a publisher, as all of us obviously do, that believe that this stuff's important, and no matter what the cost, no matter what the profits, we're going to keep doing it.
Right. Thank you.